in Reflect 2021. The topic of what I have been asked to talk is indirect calorimetry. And is it the gold standard? Hello friends, at the outset I know that nutrition is very important to all inviting patients because if you reflect about 900 grams of muscle mass, and that can also prolong the length of hospital stay, increase the morbidity, increase the mortality, can also compromise the immune function, and can also definitely precipitate secondary infections. So therefore, exact delivery of this energy or calories, which is very important, and in order to determine it, we need to know the basal metabolic rate as well as the energy prescription or the resting energy expenditure. Various tools have been used to find out exactly how the calories should be found out. We have used the subjective global assessment. The most important gold standard is indirect calorimetry. Of course, it is quite costly, not very easily available into all intensive care units, and it is one of the most standards and clinically recommended means to measure the energy expenditure. Various other means and alternatives have also been found out. We have also been using the thickness, we have also been using the Nutri score, which can also predict exactly how much amount of calories should be delivered. But exactly knowing the amount of calories, depending upon the energy expenditure, the exact gold standard tool is indirect calorimetry. We know that we get Joule energy, and the exact amount of energy is given by the nutrition what we feed the patients. And this comes from proteins, carbohydrates, as well as lipids. And various softwares and tools are available which also help you to calculate the amount of energy requirements as well as energy expenditure. But the most important things which is really required for all of us is the energy output. Because the energy output and the metabolism or the chemical changes which occurs in these chemicals critically in patients, they definitely hamper the metabolism. There is abnormality in the body temperatures as well as the requirements also because of the hypercatabolic state. So most importantly, the three energy requirements which are important for us to exactly deliver the amount of calories which are required to the patient is the basal energy expenditure, the resting energy expenditure, the activity of the patient, and also the thermogenic effect of the food. So the basal energy expenditure and the resting energy expenditure. The basal energy expenditure, it is the sum of all the working activities behind you of the body here at total rest. And this is maybe expressed as kilocalories and also called as the basal metabolic rate. And this basal metabolic rate also varies from person to person. It also depends upon the metabolic functions, diabetes, hypothyroidism, and also the stress factors which are responsible for the patient or which are present in the patient. But most important, we need to understand that the resting energy expenditure is not exactly the same as the basal energy expenditure, because maintaining the exact stringent conditions required to measure the true basal energy expenditure is very difficult, and therefore most often what we measure is the resting energy required. Now the resting metabolic rate, we know it can be best measured with the help of indirect calorimetry and also responsible in the sugars as well as the thyroid function test. And the indirect calorimetry is gold standard. Definitely the indirect calorimetry measures the basal amount of energy expenditure which is required as well as consumed, because any amount of nutrition which is delivered to the patient, definitely that acts as a fuel, and when the patient has been fed, there are metabolic modifications which occur depending, and that can give rise to calories or heat and energy production, and that gives rise to synthesis and combustion or a hypercatabolic state. There is a breakdown of lipids, carbohydrates as well as proteins which, if not adequately fed, will definitely lead to weight loss, malnourishment, and definitely prolong the length of hospital stay, increase the morbidity, increase length of hospital stay as well as secondary infections will also occur. But more importantly, exact amount of energy expenditure, the exact calories which are really need to be delivered to the patients, precisely, that is very, very important to us. And indirect calorie systems can be found out by 4 ways. We have got the confinement methods, the closed circuit systems, the total collection systems, as well as the open circuit systems which are important. I'll not go into the details of it, it's more of a biochemistry which is important, but more important, the science that quantifies the release of energy from the metabolism is called as calorimetry. And indirect calorimetry indirectly measures the same. And what we saw, it is either a direct or an indirect. And the indirect is the open circuit, where we see from the expired gas analysis or the carbon dioxide nitrogen excretion which occurs, and the respiratory chamber. Mind you, we have got certain alternatives methods. There are certain specifically designed machines which are also available as indirect calorimeters, which are available in certain bigger tertiary care hospitals, and which really quantifies the amount of energy expenditure and helps you to deliver nutrition very precisely to the patient depending upon the needs as well as the requirements. As we said, feeding is important. So giving calories to the patient is important, and as per guidelines, we definitely start off with 24 kilocalories depending upon the body per kg body weight, and definitely depending upon the stress factor, we increase the calorie count and also the protein content. And calculating of this energy expenditure, what we must really know is the oxygen consumption of the VO2 max, the resting energy expenditures, what is the calorie equivalent, and what is the exercise duration. These are the formulas which we have taken from the book. And it also depends upon what is the stress factor of the patient, whether the patient is being dialyzed, whether the patient is being ventilated, whether he's on ECMO, whether he's on CRRT, whether the patient is in septic shock or ARDS. It all depends upon the stress factors which are important. Now, the importance of applications of indirect calorimetry is really into intensive care units, but also into non-intensive care. It also helps you to exactly maximize the cardiorespiratory and the muscle endurance systems, the metabolic activity, whether it's absolute or relative. It also tells you the accumulated oxygen deficit, the metabolic rate, and most importantly, the energy expenditure and the VO2 max and the oxygen consumption for endurance. And this is mainly being used for high altitude or marathon runners, or also in patients where proper nutrition needs to be given, or trainers, which is important. Various other methods like indirect calorimetry to exactly amount and quantify the energy expenditure are available. As we said and I discussed at the talk initially, that yes, definitely using the subjective global assessment, using the various other tools. We have also got the MMR techniques, the Nutrix score, but technology has also played a very important role. We have got now softwares which also tell you the amount of calories and the energy expenditure. Certain companies like Hamilton as well as GE have also come up with CareScape, and they have also incorporated into the mechanical ventilators where, depending upon the gas exchange, the exact amount of energy expenditure can be measured with the help of different modules which are easily available, and they really help you to exactly, precisely tell you the energy expenditure as well as the requirement, and really help you to fine-tune the nutrition support and the nutrition prescription in all these patients, because all critically ill patients require expenditure as on a continuous basis. And definitely it has got limitations. The limitations is here exactly the whole body is taken into consideration, not just simply one part or one specific organ. We definitely need sophisticated gadgets and technology and expensive equipment, not as compared to easy subject global assessment or just calculating the Nutrix score. It is very sensitive, and definitely as technology is involved, definitely certain amount of errors will also be there. And most importantly, we can accurately use for metabolic intensities the energy expenditure, more importantly in the steady state. That's very important. And here you need to have sophisticated devices if you're using it in a non-intensive care unit. As far as the intensive care unit, yes, it is useful. It is definitely precise. It helps you to deliver the exact number of calories. And P.S. India also came up in this pandemic with giving the practical guidelines for the use of indirect calorimetry, and he definitely recommended that indirect calorimetry, it is one of the best tools to assess the resting energy expenditure in all critically ill patients. And even the European Society as well as the American Society have recommended to use, and he also published it in the nutrition. The further recommendation also given was, in all mechanically ventilated patients, we really need to use the energy expenditure should be determined using indirect calorimetry, and this has got very strong consensus, almost about 95% agreement at the grade B of recommendations. And if indirect calorimetry is not available, definitely the VO2 max or the oxygen consumption from the pulmonary artery catheter or the carbon dioxide production VCO2 derived from the ventilator, it will be better for evaluation of the energy expenditure than the predictive equations. And this also got almost about 80% consensus. Another trial which came up from China, which was also published, also delivery of the energy using the indirect calorimetry. This was again a randomized trial and a meta review analysis. He definitely Dr. Dion suggested that use of indirect calorimetry is increasing because of the precision in calculating the exact energy expenditure, the resting energy expenditure measured in these critical ill patients, and it really helped them to target and exactly fine-tune the nutrition support of all these patients on a dynamic basis, and they compare the therapy with predictive equations as compared to the standard of care. And they significantly observed that, yes, definitely we have taken into consideration overfeeding or underfeeding, but they found that significant higher energy was delivered per day into the group where indirect calorimetry was used as compared to the other standard of care, and also into the group where indirect calorimetry was used. Indirect calorimetry guided energy delivery significantly reduced the short-term mortality, and more importantly, did not significantly prolong the duration of mechanical ventilation or the hospital stay or length of stay into the hospital. Even Pierre Singer came up again in clinical nutrition in 2019. He suggested that yes, determining the exact energy requirement is very important for fundamental support in all patients. Indirect calorimetry has been the gold standard for assessing the resting energy expenditure, and most importantly, measuring this is recommended, particularly in situations where you require adjustments of energy is very crucial, especially in all our critical ill patients. The results of these indirect calorimetry can definitely lead to changes in the treatment, since the changes can be carried out on an immediate basis at bedside, and this has to be considered as a point of care. And beyond the aspects of nutrition support, studies of energy expenditure with indirect calorimetry have brought more understanding about the metabolic changes which is occurring during the natural course of these disease or these critical ill patients, and definitely which require other interventions and which can also change the treatment plan in these patients. And various studies and also have recommended that indirect calorimetry is one of the gold standard techniques. It also helps you to fine-tune the treatment and also reduce the morbidity and mortality. So one of the conclusions from this study is that yes, indirect calorimetry is one of the gold standard ones to determine the energy delivery into these patients. It significantly reduces the short-term mortality in critically ill patients, and it encourages the use of definitely energy delivery during critical care nutrition support. Thank you very much, and again thank the organizing committee of FitMed 2021 for inviting me to talk, and I'll be very happy to take any questions. Thank you very much.
Nutritional therapy is the main role in management of patients in ICU. So it is individualized nutritional therapy, not like routine nutritional support. So once you assess the energy requirement, basal energy requirement or resting energy expenditure, and you can by means of indirect calorimetry, so that you can guide the exact nutritional therapy for that particular patient to improve the mortality. Thank you, Varlakshmi, for giving the academic committee for giving the opportunity. We will take the questions from the audience for 2 to 3 minutes.
My question is to Dr. Kansham. His lecture on dexmedetomidine. So we always believed that dexmedetomidine drops the blood pressure and drops the heart rate, and it increases the noradrenaline requirement. But this new paper he quoted states that it decreases the noradrenaline requirement in ICUs, and I don't know whether to believe this or the previous beliefs we had. And then it goes further, giving explanations for decreased NORAD requirement in dexmedetomidine cases. I mean, I'm actually surprised, and I don't know how others are feeling. So, what do you think? Is it what was wrong? Is this paper wrong, or what we believed was wrong regarding dexmedetomidine and norepinephrine?
This paper was only considering situations where there is a excessive release of endogenous catecholamines, which typically happens in patients with sepsis and septic shock. So again, in a normal patient, this phenomenon will not be observed. This is only in situations where there is a hyperactivation of the sympathetic system. There is a lot of catecholamines which are released, and we know that when there is a lot of catecholamines, there is desensitization of the adrenal receptors. So there, if you have an agent which can act at a central level as a sympatholytic and decrease your endogenous catecholamine release, then the resensitization of the alpha receptors happen. As I said, though this paper looks very interesting, the numbers are very small. This is subgroup analysis, and maybe in our own clinical practice, if we have seen, if inadvertently we have put patients who were on severe septic shock with XM, maybe we could have observed this. But as I said, this is only a subgroup analysis, not something we should be taking directly and applying in the patients. We would still need a lot of research on that. But there is, this concept not only with respect to XM, but even with other alpha-2 agonists and other sympatholytics has been shown in patients who were sensitized with the alpha-2 agonists before. Patients with cardiac surgeries, patients with septic shock, and animal studies it was shown. So, interesting concept. Can be applied straight away to intensive care? Probably not. We still have to wait for more evidence to come. But as I said, at best, this is a hypothesis generating.
Thank you.
Thank you, Arjun. Yeah.
Hello everyone. So my question is to Srinivas Sambhav sir. Sir, I think you know me before also, like we met in Hyderabad. So my question is, sir, for one of your last statement for early versus late RRT is, we don't know how late is late, and are we going to cause more harm by delaying our late initiation of dialysis? And you compared all the four the RCTs on early versus late. But my thing was like, the START AKI trial, which is the latest, multi-center, the biggest trial, where the comparison group is the standard initiation of RRP, which actually said when you have acidosis or hyperkalemia or fluid overload in terms of PF ratio, that actually had no difference when you're starting it early. So can we actually modify saying that we know how late is late? Late is once we have the standard indications for dialysis, then we have to start dialysis.
I am somebody who grew up in critical care with the belief that the moment you see acidosis in a septic patient, you should initiate RRT. This is how I grew up in intensive care. That was my belief for about 10 years. Now, sometimes you don't get machines. Sometimes you don't get clearance from the credit organization. Sometimes the patient doesn't give consent. The patients don't get RRT started when you want it. And when you really get everything ready, they don't get it. They would have survived. In your belief, they should have died, but they have survived. So that's what set me thinking. The RCTs are coming. But to answer your question, acidosis is a broad term, right? Any bicarb that is less than 20 is acidosis. Any base excess that is less than -2 is acidosis. Anything that is more than 5 is hyperkalemia. Any fluid balance that is more than 500 ml is a positive fluid balance. Now, if I initiate dialysis or renal replacement therapy at a bicarb of 19 versus a bicarb of 14, what is the difference? Who has studied that? Am I correcting numbers? All the data I have as far as late initiation or conventional indication of dialysis, as you said, acidosis, hyperkalemia, hypoxemia, hypervolemia, whatever it is, they are all numbers. There is no hard and fast clinical parameter which tells me that this is unacceptable. There is this concept in intensive care. When you look at severity of acidosis, we take great pride in saying sub-7 pH. Right? There are people who have survived with 6.9 pH also. Right? So it might be, for example, in permissive hypercapnia, you want to intervene when the pH drops below 7.20. Why? Has anybody shown that the heart stops beating at a pH of 7.19 and it starts beating again at a pH of 7.21? Has anybody shown that? You say that carbon dioxide above 60 is bad. So has anybody shown that the heart stops beating at a CO2 of 61 and starts beating at below 50 at 59? You don't. So while early initiation within 12 hours has not been shown to confer a benefit, how long can the body be allowed to compensate for the homeostasis that is being deranged? Nobody knows. That's my last point. We don't know how late is too late. So suppose I wait till the bicarb reaches single digit. Patient will die. Somehow he will die. He may die of acidosis, he may not die of acidosis, but he will die. Then are we going to go back and blame ourselves saying I waited too long to initiate renal replacement therapy? I don't know the answer. Right? DKA patients typically survive even with a bicarb of 10. CKD patients don't get arrhythmias with a potassium of 6. Right? CKD patients are in the community with a pH of 7.28, 7.26 with metabolic acidosis. They don't die. So, what exactly is the pH? What exactly is the bicarb that deranges intracellular metabolism? We don't know. So, how long I can wait, I don't know. But definitely I can wait up to 48 hours, is what I know.
Again, I don't know, I'm not prolonging, the thing about START AKI trial is about the standard therapy group, where actually it is about new onset of AKI, not like CKD or getting AKI or CKD for dialysis. So new onset of AKI, and they have like definitive indications in terms of pH less than 7.5 or bicarb of less than 12 or PF ratios less than 200 or potassium more than 6. So this is all about new onset of AKI. So can we extrapolate the standard group of START AKI to our clinical practice to start dialysis?
So standard, if you look at the standard deviations of those average numbers of bicarbonate, the variance is too high. It is ranging from, if you take the mean bicarb of 16, the range is between 12 and 18. So you mean to say you can wait till 12 and you initiate at 18. Right? So that particular number or particular combination of acidosis hyperkalemia where life is no longer sustainable is not known, will never be known, because no two individuals are the same. That is my question when I say how late is too late is not known. So when you don't know when is too late, you err on the side of caution and attempt to start early. That's the mistake we make.